Hello everybody and welcome to 5 Minutes With, and we are joined today by Dr. Joanna Shakespeare, and I would really like to hear more about what it is you do and your interests, and we're also joined by Adrian. So over to you, Joanna, if you would like to tell us a bit about yourself.
Absolutely. Thanks, Phyllis. Thanks, Adrian. So as you said, my name's Joanna Shakespeare, and I'm a consultant clinical scientist working in sleep and ventilation in Coventry. Spent majority of my career heading up physiology services in Birmingham and then in Coventry, moving into a consultant position over the last few years. As well as that, I'm also the current chair of ARTP, and that's the Association for Respiratory Technology and Physiology. And obviously, it's an awful lot of our members that are responsible for the diagnosis and treatment of a lot of sleep disorders.
Yeah, thank you very much for that. I've had the privilege of being at the ARTP last year and again in Belfast this year for the 50th wedding anniversary. It's going to be a great event. I'm so looking forward to it.
Yeah,
so,
no, we're very
wedding anniversary.
It's not our wedding anniversary though, but it's
the consultant clinical scientist role is really a big deal in sleep medicine, because I don't know that we actually have enough of them. And you know, I was involved as a specialist nurse delivering sleep medicine services, but the role for me is a really interesting one, because I need to learn more about the complex stuff that I don't know, because I only know the limited stuff. But do you think it's a role that will continue to grow across the UK?
Yeah, no, hopefully. And it's something that as a professional body that we're working really hard to promote. What's the benefit of having a consultant clinical scientist in a post? It doesn't have to be in sleep medicine, you know, it can be in other areas of respiratory medicine as well. But I think we know that we've got workforce issues across all of the disciplines, be that medicine, be that nursing, and AHPs. And it's just that as healthcare scientists within this remit, we just tick a lot of boxes. We understand the diagnosis, we understand the treatment. So it's quite easy for us to run with those kind of services and fill some of that workforce gap, but also, you know, work really nicely with our colleagues, such as our medical college. And we, you know, we can bounce off each other and bring different skills to manage the patient.
Yeah, I mean, I think that in my previous role, I felt that I was in that similar space to you, but we didn't have the privilege of having any clinical physiology within my sleep service, and I was always trying to actually address that particular gap. But yeah. Adrian, have you any questions you would like to ask?
No, I'm just, yeah, great. Wow. Okay, so I'd like to steer it back to what we're here to talk about at the end, the awake check, which has brought us together at this moment. Phyllis, we looked this morning, and the recruitment so far 1510, I think. So we're getting there. With some big plans afoot for involvement of the regions of the UK, but we're waiting for these things to come to pass, as they say.
So it arose from an idea of it was a clinical paper that we read from one of our co-researchers in Buenos Aires. And after I'd read his clinical paper, I thought, we don't have good prevalence data in the UK. So that's how the awake check came about. And there's a lovely paper just published in Thorax a few days ago that is bringing us closer to some prevalence data, but we don't have that really good data yet. Is this something that you think is important, that we learn more about how many people are actually coming down the line that are undiagnosed?
Oh, absolutely, because I think what we know is that we're having a lot of difficulty managing the diagnostic burden that we've got, and we're struggling with that when we don't even know the full burden that we should actually be trying to establish workforce pathways for. So the more that we can understand what that prevalence is, we can design our pathways and you know, and our diagnostic situation just to try and manage that demographic. And plus everything's changing all the time, isn't it? So that the type of patient, I think we know a lot more about sleep apnea than we did before. It's not just your middle-aged overweight man who we need to be seeing clinic, and so we're starting to have a better understanding of that. Actually, no, this could be 50-50 men, women in middle age, and we need to get that information out there, and we do that by doing things like this, don't we?
Yeah.
Absolutely, and that's the point. So the awake check, and the difference from what we're seeing with other studies, and you mentioned the one that was published just recently, was it in Thorax? The awake check is before medical recognition. It's not sort of, you know, looking at data from the GP. No, this is recruitment via social media and through pharmacies to actually get people before they've been recognized. there's all sorts of qualifications and we'll have to make to that, but yeah, we're going to try to get to a large enough sample size to actually have a picture of how common these issues are across the UK. We'll keep going. So it's your help like this that, you know, keep banging the drum.
And we'll do whatever we can as an organisation to promote it as well and get as many more people to complete that survey for you.
We won't have enough data for this year's ARTP for any abstracts, but we will have something for next year.
Brilliant. Excellent.
I'm pretty sure we'll have something for next year, which is really quite an exciting prospect.
Yeah, absolutely.
It's a wonderful prospect. It's starting to come together. There's, you know, so I think, what do you? I think we've got it. I don't want to bore people to tears and don't want to falling asleep. But on that note, thank you very much.
Thanks very much for speaking to us.
Thank you very much for the invite.